Hi.
Cheers. How are you?
I'm great.
Excellent. Well, welcome back, everybody. I'm Megan Cranenberg, the owner of Chrysalis Physical Therapy in Poulsbo, and we're sitting here at Crane's Castle Brewing in Bremerton, Washington for the third installment of this session of the Pints for Pelvic, Pints and, not Pints for, that sounds like a fundraiser, which we'll do some other time. But Pints and Pelvic Health, where I get to sit down with other providers within healthcare to talk about really important topics about that most of our population that we see is still new, that we're out here doing what we do. So Jake, who are you again?
Again, I'm Jake Bartholomew. I'm a pelvic health physical therapist in Seattle, Washington, specifically in the Fremont neighborhood at Flow Rehab.
Awesome. I got to get over there and see your space sometime.
Yeah.
Just high five. Hallelujah. So we've been talking about the topic of male pelvic pain. We spent the last session kind of going over the difference between what might be real prostatitis and then all the other myriad of pipes and wires, nerves and blood vessels and muscles that can be contributing to male pelvic pain. So go back and watch that if you haven't watched that one already to lead into today. But today I'd like to hear a little bit more about, okay, when someone comes into you for pelvic pain related to bad bicycle seat fit or chronic pelvic tension or post-operative changes, what's your approach? What's the treatment strategies? How do things work?
Yeah.
All you.
All right. So when the patient comes in, sometimes, on our questionnaire, we have a really long, thorough new patient paperwork.
Same.
And it's annoying for the patient, but it's very helpful to make that first session go faster and get quicker to the evaluation part and not have to talk for too long. But I do pride myself on trying to listen to their story to try to, because a lot of people have no idea what's going on, and their doctor kind of seems to have a vague idea of what's going on when they've ruled out all the bad stuff. Yeah. And so by the time they get to us, the more detailed our questionnaire is about their life, it helps me focus my evaluation so we can kind of get to the most important part then is treatment. Yeah. And so that evaluation is just really key to help trying to set up then where are we going to go from there. And a large part starts with education. First, just about what is pelvic health, because a lot of these guys, they tend to Google it, and then they're really scared that all I'm going to do is a rectal exam, and they're really scared, and they don't know why I'm going to do it or what that means.
That's the same in women's health too. There's definitely those are sacred muscles. They're muscles, just like neck muscles and shoulder muscles, but we hold them in a different place.
Right, because they're not taught that they're muscles. They're taught that that's a private part of their body that no one touches but them or their partner or their physician.
Yeah.
And so, even though we're a medical provider, it's still kind of a little bit out of their paradigm that physical therapy is going to touch this part of their body, and why? Because they're not aware, again, that it's muscles and tissues and bones and ligaments.
So aside, kind of taking the 10,000-foot view and not just looking at pelvic floor as it's just there, what does your evaluation look like? What are you looking at?
Exactly. So I like to start, again, still using my outpatient orthopedic brain I started with, and doing a quick kind of lumbar screen and movement and lower extremity strength and range of motion, and kind of see, especially for these guys, and athletes or not, and they have kind of this vague pain. I want to look at what are their hip flexors especially. I do a pretty quick screen there. And then, of course, hamstrings, and then adductors. Their adductors can really, that tissue attaching to the pelvic bone and the fascia around it, I think can contribute significantly, whether it's primary or secondary to what's going on.
Amen. And for those watching at home, adductors, what are adductors? They're the muscles on the inside of your thigh that bring your legs in. So those machines at the gym that usually only like 23-year-old girls are using that go out and in, the one that comes in is working those adductors.
Right, or people that say they got a groin injury, usually they're pointing to their adductors when they're strained in there. So I try to look at those big muscles, the hip muscles and stuff, and this is someone usually has their underwear on still for me to look at these. And then once I kind of get an idea of what that looks like, when I have them undress and look more closely at their abdomen and around their genitals and around their external pelvic floor. And I'm looking there for tissue tone and color and just differences in skin integrity because a lot of these areas they can't see. And we could gain a lot of information if there's redness or a little tear or something.
Like we talked about in the last session, it's important for us as direct access providers in Washington to be screening those areas. So you're having this vague pain, maybe it's muscular, but maybe it's not. And we might be the first person to kind of get a really good visual on these tissues to rule out for signs of infection or disease.
Absolutely.
Yeah.
Or a little tear like a fissure or a hemorrhoid that I think is still relatable and something we can address. But at the same time, they might need a cream or topical something to help with the pain or healing of whatever that issue might be. So they might have to be sent back at the same time to see their gastroenterologist or colorectal surgeon or their primary care doc.
Yeah. So, evaluation, you looked orthopedically, hips and adductors, and directly at those pelvic floor tissues. And abdominal wall, what are you looking for in the abdominal wall?
Again, tissue integrity, muscular tone, tension, can I reproduce pain? Those are the biggies.
Yeah. Are you asking in your paperwork about like constipation and
absolutely
hesitancy or pain with urination?
Yeah,
I
both.
already know the answer to this.
Yeah, we ask very thorough questions about their bladder and bowel daily activities and issues and frequency and difficulties.
How might bowel stuff and like a deep, vague, weird, deep pelvic pain be the Freudian slip there, constipated. How about those be connected?
In multiple ways. If they're constipated, they could just be backed up and just have uncomfortable discomfort, bloating, and that could be related to a really tight pelvic floor and they're having difficulty evacuating their bowels properly. On the other side, if they have a lot of diarrhea, loose stool, or incontinence issues, and they're just trying to tighten down there all day long, all the time for trying to hold it in, they could be really creating a lot of tension and muscular tension by trying to use everything so forcefully. And so they're just creating muscle knots and tension.
Okay.
That's fine. Yeah. So then we look at abdomen, and then I'm also looking more specifically at their pelvic floor and movement. I'll have them kind of contract and relax, like they're holding in gas or holding in a bowel movement. What does that movement look like? I watch their sphincter in a male. I'm watching their testicles to see if they raise when they're contracting. How much motion do they have? Can they relax? And how quickly can they relax when I say it? And then just the opposite, can they bulge like they're trying to pass gas or pass a bowel movement? Is there distension? Does their pelvic floor descend properly?
Okay.
So I'm really looking, and that can give you a lot of information.
So much information. Okay, so when you're looking at someone's pelvic floor and asking them to contract or hold in the gas or bulge like they're trying to let out a gas or bowel movement, and you're talking about how quickly that can happen, what are the implications here? Why is that important to have that control?
That's telling me a lot of information about those muscles. Those muscles need to be able to contract to help support our pelvic floor, our organs down there. They need to contract to help maintain continence, both bowel and bladder. They needed to be able to relax, especially for passing of stool, and to relax for voiding. We have to be able to relax those muscles. And with exercise, especially, they need to contract a little bit more to help support our abdomen, abdominal organs.
These pelvic floor muscles are really important with exercise. So like looking at someone who's doing a lot of CrossFit or powerlifting, if they don't know how to, cue it and then let it go too. I think, one of the biggest myths that we end up always having to bust about the world of physical therapy is that it's all just, or pelvic floor physical therapy, is that we're just teaching Kegels all the time, right? Oh, everything will be fixed if you know how to really contract those pelvic floor muscles. When it sounds like for male pelvic pain, that might be one of the last things we want people doing. I don't know, talk about that.
Yeah, absolutely. People tend to just think, pelvic floor, the only treatment they know of is doing a Kegel, and they're contracting their pelvic floor to help whatever the ailment might be. And a lot of times I'm finding for men, I need to teach them the opposite. They've got to learn how to relax their pelvic floor. It's too tight. And it might still be weak and they might need strengthening, but nothing's going to get better until we learn how to relax those muscles and get them back to a proper resting length and get out any knots or tight spots first.
So one of the questions that I get a lot from folks when they're thinking about starting PT, and you probably hear this too, is, well, how long is this going to take? How many sessions am I going to need? How long? And, I kind of punt that back to them as there's no crystal ball, but sometimes I have a pretty good idea. Do you see a trend in, let's say, kind of the typical male pelvic pain? He just needs to learn how to kind of let that down and manage his stress during the day. How quickly are you seeing results with this?
That is such a tough question, and there's
Sorry, I totally did it to you.
Absolutely, because the patients ask it all the time, and I hate that question.
Oh, we all hate it
because I want to give them the great answer of, in 2 sessions, you're going to be 90% better, and I can't promise that because it really depends on that person and their lifestyle and what are they doing the 23 hours a day. Then I'm not seeing them, or in the rest of the week, the 6 days, I'm not seeing them. And so if it's more obvious, like they had a trauma, they took a blow, they had a fall on their tailbone, then it can be more straightforward, and I can give them a better answer that, this tends to respond quickly because you just had an acute injury that will heal, and especially if they were totally fine before that. But if they come in and they're talking about 6 years, 8 years of prostatitis that's bugging them on and off. And I can just tell by the way they're talking and sitting that they just kind of have a baseline high anxiety, and they talk about their stressful job and a divorce and buying a house and, just all these life stresses. I can tell it's going to take a lot longer to teach them how to relax overall and not keep holding tension in their pelvic floor. Even I can help speed it up by helping get rid of those knots, but if they're not addressing their internal anxiety and stress, it's just going to keep coming back.
Yeah. So it can sound a little doom and gloom, or I think of someone watching this going, I was really excited about starting pelvic floor therapy for my pelvic pain, and now it might not be that quick, right? It can be disheartening maybe to hear, but we still see what's at the other end of this, for the guys that go, okay, commit, I'm gonna take what you told, I'm gonna see the counselor, I'm gonna do my diaphragmatic breathing every day. What are what's at the other end of that tunnel?
Right. Well, and that's what I try to tell them is it might be a long-term treatment strategy and timeline, but hopefully within a few weeks or 2 months or 8 visits, maybe you have 50% less pain with intercourse, or you're only leaking half the time you're exercising. You're going to see progress at least along the way. You might not be 100% for 6 months or a year, but at least we're going to see progress. And for a lot of these people, any reduction is an improvement, and they're really happy. Just the fact that it's not getting worse. Someone knows what it is. Most of them relax so much just when they say, am I the only one like this? Have you seen this before? And I'm like, oh, absolutely.
So much, right?
Yeah,
reducing fear and normalizing that experience is huge for reducing pain. It was some, when you were talking about kind of listening to people's stories, and I think some of the power that we have of we've heard these stories so many times because this is all that we listen to. I love it when people kind of go during that history part of a new patient evaluation. This is probably totally unrelated, but maybe this makes sense that this is happening. And I'm like, absolutely, that's totally part of this profile. And they're like, oh.
Yeah.
Cool.
I love it when they think to mention, maybe it's not related, but, and I'm like, yes, your broken toe and you're in crutches and a boot for 6 weeks, and you changed your gait, and you ended up holding a lot of extra tension and stress in your pelvis because of that. It makes absolute sense. I'm so glad you mentioned that.
Yeah. Well, and I think it's a nice way for people to acknowledge, they have inner wisdom about their bodies, and they're the only person who can feel this from the inside out. And they've been feeling that progression and pattern, and maybe it's spiraled around, but to kind of to hold space and honor that your body, and maybe you haven't been taught to appreciate it, but you're feeling that.
Right. And we have more time as physical therapists, luckily, to get that information out of them.
Yeah.
That's what's nice about our field is at our clinic, we have 1 hour visits.
Same.
And, and their last physician appointment was probably 10 minutes, if that. And
where they just sat in one spot in a gown the whole time, right? They're not looking at movement, and they shouldn't be. That's not their job.
Right.
Send them to us.
Right. And sometimes even I don't get all that information out of their paperwork, and the initial evaluation might be just chatting with them on their next visit. And we start talking a little bit more about, they're like, oh yeah, I forgot to tell you that I do drink 10 Diet Cokes during the day. And I'm like, okay, all right. So you have a lot of bladder irritation that you just weren't aware of, or you're drinking a case of LaCroix, and so, gotcha.
Oh, LaCroix.
So, yeah. So
Carbon dioxide is a bladder irritant, everybody. So.
Absolutely.
So treatment, so we're moving. So we've talked about what you're assessing and looking at. What are give me your top 3 or 4 for male pelvic pain. What are they going home with? What are they working on at home?
Absolutely. So that first day, I might not have a lot of time to do treatment, like hands-on treatment, but I'm trying to educate them before they leave the door as to what's going on, and which is going to help them relax. And if they just start relaxing already, we're helping decrease some of that tension in their pelvic floor, just because if someone's listening and knows what's going on, and they suddenly have hope that it could get better, because up until they saw me, they didn't have much hope that it was going to get better. So that alone, the education is huge. And then we tend to, for a lot of these guys, end up talking about posture and what different postures and the stresses that's putting on different parts of their pelvis and those muscles. Talk about breathing. So many people, especially if they're stressed and anxious, are breathing mostly in their upper chest, and those of us fighting dad bod and a gut or a belly, they tend to hold tension in their belly because they're trying to keep it firmer. And
that never happens with women ever.
And when you do that, you're tightening your pelvic floor usually also. So I got to teach them how to let their belly go and breathe into their belly, and that right there helps them relax a lot more. I get them going on some exercises, some stretches that are more obvious, like maybe for their hip flexors, quads, adductors, and then more specifically kind of that contract, relax, bulge type, and how to relax their pelvic floor, and give them some feedback, like with either their finger or my hand, what it feels like when it's contracting, when it's relaxing, to build that awareness so they know when they're contracting and when they're relaxing. And then of course, in therapy each time, I'm doing a lot of hands-on treatment. I feel hands-on myofascial release techniques, trigger point release techniques is really, really key to help increase blood flow to the area, help increase their awareness, and help get rid of some of those tight spots and tension that then all their home exercises will hopefully keep those results we're getting.
Yeah, same. I do a lot of hands-on in the sessions now. I feel like if people are pretty aware of their body, and I can show you 2 or 3 things, a few stretches, a few movement patterns to practice at home, I don't need to babysit you in the session doing those same things. I'd rather spend our time hearing your story, putting the puzzle pieces together, and then just get my hands on your body and give input to the brain. Am I breaking up toxins? No. Am I breaking up knots? No. I don't really think that's what's happening when we do manual work, but we're giving input to the brain and helping that person's internal systems connect in different ways.
Absolutely.
It's really powerful. Really powerful. Well, Jake, it was really fun talking to you about just male pelvic pain and your clinical approach to that, and just awesome to know there's guys out there like you and women that treat male pelvic pain too, self-included, to help close, the gender gap that's out there, because it's a really big issue facing so many guys. And I'm here in Kitsap County, where there's a lot of military population, and there's a high prevalence of pelvic pain within the military population. So, and doesn't get talked about, right?
Exactly.
But so you don't have to tell your buddies, but I can't tell your buddies, just come see me, or go see Jake, or we can, if you have questions, private message us, and we can help get you connected to someone in your area that's working with pelvic pain and erectile dysfunction and the bowel and bladder stuff that everyone goes through at some time. You don't have to feel alone with that. So thanks for talking with me about this.
Thank you for bringing awareness to it.
Absolutely. We're going to come back in a little bit. We'll check in next week. We're just going to have a chat about what gets us fired up about doing our job, maybe something that we're just excited about in life right now. Okay, see you next time.